area that I think in the community and even in academia has become a little gray has been patients who have tumors in their liver that are growing into some of the vasculature. Not necessarily the main portal vein, but we see a branch of the right portal vein, something like that. By the Barcelona criteria, those patients are stage C, and that's a group where systemic therapy has been proven to improve survival. There's a sense that, oh, it's just in the liver, we should do locoregional therapy. What's your take on that, Dr. Marshall? I mean, that's probably the group that was studied in the Y90 literature because they got TACE, it didn't work, and then we had those negative studies. But should they even get TACE in the first place?
Well, we have seen patients with extrahepatic disease do better with locoregional therapy. But locoregional therapy does not target the extrahepatic disease. So I think we still need to learn a lot more about how best to treat these patients. We're going to see in the future combinations of systemic therapy and locoregional therapy much more frequently than I think we do now. But we don't have enough data to say we should not give patients locoregional therapy.
You know, if we stick strictly to guidelines, these patients with vascular invasion are not ones that should necessarily get locoregional therapy. There's phase 3 data with sorafenib and now non-inferiority data with lenvatinib that show that this group of patients probably benefit from systemic therapy. It's proven overall survival. I wouldn't even say probably. It's level 1 evidence. So if we have a patient who has TACE and does not have vascular invasion, they don't have a car accident, so they don't die of some other disease, how do we know when locoregional therapy is no longer working and it's time to transition to systemic treatment?
Yeah, it's a good question, and I think it's something that we really need to be better at defining. So, quote-unquote, TACE failure. So what is TACE failure? And I think that if you surveyed 100 different hepatologists or interventional radiologists, you probably get about 50 different answers. And there's huge center variation. I think it's something that what I think we need to do as a field is become better at defining this and say, when should you transition? I can tell you at our center, what we do is we do something similar in terms of we treat TACE a couple times, and if you don't respond, so then if you continue to have progression at that point, then we transition to systemic therapy.
So when you say don't respond or progress, if they say they have a solitary lesion, because I think there's two types of progression. There's a solitary lesion that gets treated, and then they develop a lesion on the other side of the liver, versus that one lesion that keeps getting bigger.
Yeah. I think honestly both are worrisome. And so I will tell you that what we will do is if you have progression in that lesion that you have been treating, I think that it suggests that it is not responding to TACE. And I think then we will definitely switch over to systemic therapy if you have a couple of TACEs and it grows. If you have a new lesion on the other side that has not been attempted to be treated, then we will give it an attempt at locoregional therapy there. However, once again, when you take a look at that tumor biology, it shows that you are having metastatic, intrahepatic metastatic spread. It does suggest that that tumor biology, you are at higher risk of once again continuing to have progression despite treating with locoregional therapy. So we will it will lower our bar to switch to systemic therapy if you have either form of progression.
I think that's a great word, this intrahepatic metastatic spread, right? It's still the same organ, but it's spreading within the organ. And that you just don't need to have spread outside of the liver to be considered advanced.
But I think that but once again, it goes back to the idea that you can't take anyone at one snapshot. You can't just see the tumor's within the liver. I'm gonna follow the BCLC, they're at BCLC stage B, I'm gonna go down to TACE. I think you really need to take a look at what the natural history of this person is. So they started, you've treated them, they've progressed. And so even though you could theoretically do something like another chemoembolization, you should consider something else. The line that I use in our tumor board a lot is the definition of insanity is to do the same thing over and over again and expect a different outcome.
I think.
Yeah. So I think it's the type of thing where we need to be better at this. And so I can tell you in our center, we've become more cognizant of this. And despite, the interventional radiologist saying, I can do this, we say just because you can doesn't mean we should. And so we have transitioned those people over to systemic therapy earlier.
So like here, I'm sure a very lively discussion at your tumor board, right? Arndt.
So I think one point is, if you have progressive disease, either of the treated lesion or of untreated lesion, I think it's pretty clear to switch and you have a good argument. So I think it's more difficult to decide how you proceed with patients that have stable disease. Yeah? And I think in general we have accepted in oncology stable disease as an acceptable outcome for systemic therapies, for example. But I think in HCC we cannot accept stable disease as an efficient outcome when we treat patients with local therapies. So I think progressive disease is clearly a failure of TACE, but I also think that stable disease is also an indication of TACE failure, and we really have to double think many times how many times we should treat our patients. I agree that we can treat patients twice. I mean, that's okay. I mean, if you have additional vessels that can be successfully treated. But after that, if you do not receive or get a response after 2 treatments with TACE, I think we should be very careful to continue with TACE.
So, Richard, you have a patient who you have in the interventional radiology clinic. You did a chemoembolization, they come back, and you had a good result. A few months later, they now have a new tumor on the other side. How are you approaching that patient?
Well, whenever I see something that I would define as a treatment failure or new disease or expanding disease, I always have to ask why. In particular, did the treatment that I do miss something? Did I embolize only part of the tumor and leave some behind? These are questions that I need to answer before I decide what is the next step in treatment of this patient. So in a patient who has a new tumor at a distant site, if it's something that I think is really a new tumor, then I like to reset the clock for that patient and start treating it as if it is a brand new single site, if it's possible to do that. Now, this is reading between the lines in what guidelines are and what recommendations are. But it's very important to know that a TACE failure or a treatment failure is because it's a real failure and not a miss.
In your opinion, when does someone transition from locoregional therapy to systemic therapy outside of metastatic disease, right? Intrahepatic progression. When would you say to your colleague or to the patient, I can't help you anymore?
Well, this is a complex question. I think 2 TACE failures is certainly a good time to move to systemic therapy. But it depends on multiple things. If this is a patient who's got really good liver function and could still stand another treatment, the tumor biology is good, then it may be time to have a discussion with that patient and say, I would like to offer you this additional therapy. This is not what I typically do, but given that you have good liver function and very good tumor biology, I think we have some time to do this. However, there are other patients with bad tumor biology that we know are not going to respond to TACE very well.
Let's be a little more specific, I guess, for our audience. Bad tumor biology.
So patients that don't respond to 2 TACE procedures, I consider that bad tumor biology, provided the procedure's gone very well.
So a patient has a tumor that's in the liver, but now it's progressing into the portal vein.
Right.
Is that a patient who you say you need more locoregional therapy, or do you say we need to put you on systemic treatment?
That's a patient that I move to systemic treatment fairly quickly. There's not a whole lot that I can do to control that portal vein invasion very well. And we need to use our diagnostic radiologists to define these things prior to starting treatment or immediately after treatments. It's imperative that we look at these signs: nodularity around the periphery of the tumors, invasion into vascular structures, intrahepatic metastases, to help triage these patients into better treatments.